Great. Well, good evening, everyone. I'd like to welcome everyone to this Resident Alumni Retinal Grand Round session. I'm Dr. Carolyn Major, the Director of Residency Programs at the Oklahoma College of Optometry, and I'm very fortunate to have with me here this evening Dr. Joe Pizzamente, an esteemed professor and chief of the Retina Clinic at the Rosenberg School of Optometry in San Antonio, Texas, who will be co-moderating the session with me. Good evening, Dr. Pizzamente. How are you?
Doing well, Carolyn. It's good to be with you.
And I'd also like to just take a brief moment before we get started and deeply thank Zeiss and particularly Hanayo Spitz, the head of Optometric Diagnostics Professional Education, who spearheaded the organization and production of this event. We greatly appreciate the support Zeiss has shown our universities and our residents. And last but not least, a great big thank you to our 4 residency graduates for the time and effort they've put into preparing these presentations and their willingness to share their knowledge and interesting cases with us. And so without further ado, let's meet our faculty.
So from NSU Oklahoma College of Optometry, we will hear from Dr. Sophia Lung, and we will hear from Dr. Laura Chan. And from Rosenberg School of Optometry, University of the Incarnate Word in San Antonio, we have Dr. Alex Martinez and Dr. Saul Mancha. And these 4 have completed their residencies, and we're delighted that they have kind of come back to share some of their expertise.
Yep, residency alum. It's amazing what a year of residency will do, how far they've come. We will have a few, about like 3 to 5 minutes at the end of each Grand Rounds case for some discussion and Q&A. So during the presentations, please feel free to put your Q&A questions in the little Q&A box down at the bottom, right next to the chat. So not in the chat box, but in the Q&A tab. And so let's go ahead, Dr. Lung, go ahead, kick it off.
All right, so my name is Sophia Lung, and I just finished my ocular disease and refractive surgery residency. I wanted to thank Zeiss for the chance to share some of my learnings from my residency. And without further ado, this is the case of the GrandPan, or Granulomatous Panuveitis. And so the case is about a 48-year-old African-American female. She was referred to the clinic for blurriness, light sensitivity, and itchiness in both eyes, and some flashes and floaters ongoing in both eyes for about 8 months. So at this point, that 8-month period, definitely chronic at this point, right? And so looking at this photo, it's fuzzy, but you can kind of make out there's a pigmented deposit on the endothelium in that cornea. And actually the spots kind of off to the side are all mutton fat KPs as well. And this patient had it in both eyes. I can tell you some other information about this patient as well. Her unaided visual acuities were 20/40 in both eyes, pinhole to 20/30. EOMs were full, and pressures were about 16 in the right eye and 17 in the left. And besides the mutton fat KPs, I did gonioscopy on her, and there was no trabecular meshwork nodules or iris nodules at this time. So what we do know is that this is obviously some kind of uveitis, most likely at this point anterior granulomatous uveitis. But of course, it would be good to know what's going on in the back. So let me show you some fundus photos. On quick glance, you can tell both these fundus does not look very normal. And I'll kind of blow up some pictures here for you. So here are the optic nerves. And there is obviously some kind of bilateral disc edema, that right eye perhaps a little bit more involved than the left, about 360 degrees of blurred disc margins in the right eye and a little bit less so on the left side. Some other findings, you've got a couple of white specks here. Those are vitreous snowballs. And of course, those we know are pars plana exudative material. And on the left eye, if you look really carefully, there's actually kind of that white vascular sheeting that's present as well too. So this is more fibrotic scarring, a little bit more chronic in nature. Again, not quite the active candle wax strippings that we normally talk about in terms of periphlebitis, but nonetheless, we know that something's been going on in this patient's eye for quite some time. And then these are a little bit harder to see on the fundus photos, and actually they were a little bit harder to see on dilated fundus exam as well. But you have these kind of poorly demarcated, patchy chorioretinal lesions that are showing up kind of scattered all over her retinas. And it would have been nice to actually have OCT angiography for this. Even though the research is fairly preliminary at this time, what we're starting to find out is that OCT angiography might actually have a role to play in visualizing some of the more larger granulomatous areas in chorioretinal lesions. So I did not have OCTA for this patient, but what I did have was an OCT, so I'll show you that instead. So many of us are pretty familiar with these printouts, but I wanted to highlight a few sections and kind of talk specifically about those. And so we have, obviously, the average RNFO thickness is pretty supportive of what we were seeing in the fundus photos. On the right eye, you have 209 microns, and then the left eye, 143 microns. And that does support what we were seeing on the fundus photos, that sort of guess or kind of assumption that there was more involvement in the right eye compared to the left. Vertical CD ratios, obviously they're going to be small because this is active edema. But the other thing I wanted to kind of bring about this was, what do these numbers specifically mean? And so there are a couple of studies, and they're pretty small studies. The N numbers are pretty small, but they do give us some frame of reference in terms of control or normal average RNFL values compared to the RNFL values in patients with disc edema. Now, there's 2 points I wanted to make about this. One, about average, let's say 91 to 103.4, let's say 100 being kind of the magic number. That's kind of our average normal RNFL thickness average value. And the standard deviation, we've got about 8 microns in the 2005 paper and 19.1 in the 2011 paper, fairly small, relatively small standard deviations. Whereas in the disc edema, the average numbers are a little bit higher with a little bit more of a broader standard deviation as far as that goes. So the second point to that is that, and I want to give a shout out to Dr. Hadel, who's one of these optometrists that I worked with during my residency, who helped me to kind of wrap my head around how to use these numbers in kind of a more of a critical way, critical analysis, I should say. And so what I wanted to point out about this is kind of bell curves. So the bell curve for the controls are going to be a little bit more narrower, whereas the bell curves for the disc edemas in terms of standard deviations are going to be a little bit broader. And what that basically just means is that OCT, we have a lot of data that can talk about glaucoma and RNFL loss, but in terms of increased RNFL, we may not be able to use it specifically for diagnostic, but we can use it to support what we're actually seeing on the fundus photos. And then going into here, you can see this patient did manage to retain the double hump integrity of her eyes, which is good in the optic nerves. But there's also some numbers that can help us with that as well. And so a couple of trends that are important to know is that in inflammatory disc edema, the superior quadrant is going to tend to be more commonly measured as above average, whereas in something like papilledema, for example, the inferior quadrant will tend to be more commonly measured as above average. So again, that can be used to supplement what we're seeing, or maybe not even seeing, on dilated fundus exams or fundus photos as well too. And these are never supposed to be looked at completely independent of each other. They're supposed to be supplementing each other, and that's where the OCT, as we know, can come in very handy. And then I like the tomograms because it can actually show us kind of a visualization of what's happening. As you recall, the patient did have flashes and floaters for about 8 months. And so you can see that there's that posterior face lifting off of the optic nerve on that right eye, and that likely is attributing to her symptoms of that chronic nature. And so I wanted to jump in here into basically the case a little bit more now. So what do we have? This is obviously a case of panuveitis. We've got the anterior chamber reaction, we have the vitreous snowballs, bilateral disc edema, chorioretinal lesions, and vascular sheathing. And because they're mutton fat KPs, this is of the granulomatous type. And many of you are probably already thinking, well, she's African American, so ethnicity plus the clinical presentation, most likely going to be ocular sarcoidosis, right? And before we anchor on that, though, it's really important to understand that GranPan actually is one of the symptoms of the great imitators group. So here's a short differentials list. It's not exhaustive, but it's good to know some of these. Syphilis obviously is one of them, sarcoidosis is there, TB, Lyme's disease, tick-borne disease, and many others as well too, that's important to know. So with this patient, I did order a few tests that I can tell you about. So her CBCO differential was normal. She was found to be ANA positive. She did have elevated serum ACE, calcium was normal, and she was negative for TB, syphilis, and Lyme's disease. We did get a chest x-ray, which was normal as well, no bilateral hilar adenopathy showing up for her. So what do we do with this information? Well, in 2017, the International Workshop on Ocular Sarcoidosis updated their diagnostic criteria. And so based on this, I'm going to run through the findings for this patient, match it to one of the diagnoses that's available under this criteria. So she had the mutton fat KPs, snowballs in the vitreous, chorioretinal lesions. She did have, even though it was old, signs of previous periphlebitis and a bilaterality in her eye. And then on systemic testing, she had negative TB test, elevated serum ACE levels, and then everything else was either negative or did not apply. So based on this, we were able to make the diagnosis of a probable ocular sarcoidosis and be able to get her the help she needs. So a little bit about ocular sarcoidosis. It's granulomatous inflammation, definitely a higher prevalence or preference rather for African background. Actually in the US specifically, African Americans are 2 times as likely to get ocular sarcoidosis. And then as far as the exact pathophysiology, it's unknown at this time, but most likely an environmental trigger combined with genetic factors in some way. In children who have parents with ocular sarcoidosis, they actually have a 4 times higher risk of getting it themselves. If it's going to go systemic, it's going to go into the lungs and it's going to go into the lymph nodes. And then, of course, as we mentioned before, this is one of the great imitators. And so before anchoring on the diagnosis, it's really important to take a look at some other conditions that could possibly cause it as well. In terms of the acute stages and the way it shows up, it's going to be in the earlier stages, anterior, bilateral, and asymmetric. Remember that gonioscopy is extremely important because it's good to look at the trabecular meshwork and the iris to look at any nodules and risk for pressure increases later on. In chronic stages, it's going to involve the anterior segment, or intermediate segment rather, and then the posterior segment. 90% of these cases are going to be in this category, and that's because it's a chronic, it's a slow progressive nature. Patients are not going to show up on day one. And so remember how, again, that patient had those flashes and floaters for about 8 months in duration? A lot of times it's going to be on a dilation looking for something else that patients will actually be diagnosed or found with symptoms with granulomatous panuveitis. Actually, 10 to 30% of patients will actually show up with panuveitis. And unfortunately, a lot of them are going to have silent symptoms. Basically, they're not going to come in saying, I think I have GranPan. So the important part of that is to make sure we're looking carefully at all the structures, because this is the stage that we don't want them to get to. The irreversible vision loss is basically where, let's say, trabeculitis or ocular hypertension has ensued for a long time. They develop secondary glaucoma, and then they develop blindness. CME, ERM are also causes of irreversible vision loss in advanced progressive stages of this condition. And so treatment-wise, corticosteroids are the first line. We did treat her with Durezol for the first little bit. We referred her to Retina to get treatment for the posterior and the anterior intermediate segments. I'm thinking of something like Ozurdex or Retisert, something like that. Unfortunately, due to COVID, she actually was lost to follow-up for a little while, and we're actually still working with her to try to get her set up with her rheumatologist as well as retina consultants. In long-term cases, immunosuppressive and biologic agents are going to be required because, as we all know, long-term steroids have a lot of side effects with it as well. In these patients, especially the ones that are asymptomatic, make sure that they do get connected with their PCP or their rheumatologist because granulomatous inflammation can target any organ system, which means that cardiac changes specifically need to be monitored for. Because you can imagine if the heart becomes involved, then fatality can be a possibility as well. So the big take home with this is actually not so much about ocular sarcoidosis, but more so about granulomatous panuveitis, in that you want to be just like Sherlock. You want to make sure you're checking for all the structures, looking at other systemic causes before anchoring on one diagnosis, because that actually can significantly change the outcome for that patient. So these are the works cited, and this is my contact information, and I will take any questions during the question and answer period. Thanks for listening.
Thank you so much, Dr. Lung. I don't see
problem.
any questions in the question and answer chat box here. Any other faculty have any questions for Dr. Lung?
Great talk, Dr. Lung. Just a very thorough job. And just like Sherlock Holmes, you're also well-trained during your residency to pick up clues. Right away, you knew that this was a granulomatous type of uveitis. And based on that, you immediately began to suspect systemic etiologies. In this case, some more of the inflammatory conditions, but I do like your list of differential diagnoses that included several of the masquerade syndromes. So I think one of those take-home messages is that granulomatous disease is usually due to something systemic, and one can have ocular sarcoid without pulmonary sarcoid.
Yeah.
Yeah. And also the thing too is with, the thing that we often see with disc edema, we often think of papilledema, right? And I know that during our discussions with, just when we were kind of rehearsing, there was a great point that you had brought up, Dr. Pismenti, that the CD ratio often actually, is somewhat retained in true papilledema, whereas in inflammatory, you end up that CD ratio of less than 0.1 is actually fairly common. The other thing too is, I forgot to mention that with Forum and Zeiss and choosing baselines, obviously in this example, this patient, if we were to use that scan that I had showed as your baseline, then really any resolution over disc edema would show an RFA loss. So really quite crucial to be choosing the proper baselines, making sure that you're choosing one that shows them in a healthy state as opposed to an active inflammatory state, just to make sure these are getting tracked and monitored appropriately and accurately thereafter as well.
I think that's a great point.
Absolutely, yeah.
I'm going to share something really quick. I'm going to see if I can share my screen here and show you guys how OCT can allow you to see vitreous cells. And so this was a patient, looked almost identical to the presentation that you just described, Dr. Long, except this patient had syphilis. And as you can see on the OCT, as we scan through the cube, it kind of looks like these falling like raindrops, which are actually vitreous cells. So I think OCT can be a great way to detect early vitreous cells that can be very subtle with fundus exam.
Yeah.
All right, well, let's move on to our next case, Dr. Martinez.
Hello, my name is Alexander Martinez, and my presentation is over myopic CNV confirmed with angioplex OCT angiography. We had a 31-year-old Hispanic male come to our retina clinic to monitor his retinal complications due to high myopia in the right eye more so than the left eye. He reports no changes in the vision since his last visit with us, which was in September of last year. He has a positive history of gout, and he struggled with myopia all his life. He reports that in his early 20s is when he had a decline in vision in the right eye. His current spectacle prescription is -8 and -3 in each eye. Anterior visual acuities in the right eye were 2150 with eccentric viewing with no improvement in pinhole, left eye 2030 -2 with no improvement in pinhole, and the following entrance tests were unremarkable. Again, anterior segment evaluation, pretty unremarkable with the exception of mild MGD in each eye, and pressures were 14 OU. And actually, I'm going to discuss the posterior segment findings in the actual fundus photos. And one thing I actually want to mention that our patient had, poor fixation, very photophobic. So the images show glare and some blurriness in the right eye, but we can still assess it. The right eye, we have parapapillary atrophy 360 degrees, and the left eye almost 360 degrees. And as you can see here, this choroidal atrophy extends all the way into the macula with pigmentary changes. And the macula on the left side is actually spared, with the exception of some pigmentary changes here, temporal to the fovea. CDs are 0.4 on the right and 0.35 in the left. Interestingly, when we look at the fundus, of course it's tessellated, it's a myopic eye, but we see these atypical punched out lesions in the superior and inferior case for both eyes. They actually extend more than what you can see in the actual image. So it's one thing we have to keep in mind as well from possible other differential diagnoses along with the myopia. And funduscopically, when I took a look at the patient, it wasn't so apparent that they had a staphyloma. But interestingly, with staphylomas, you can pick them up with ultrasound technology with B-scans and OCT imaging. And for the right eye, you can see this outpouching here. And the bottom right image, again, a little indentation here showing a possible outpouching there as well. And for the left eye, pretty unremarkable, no staphyloma that I can see here. So for the both eyes, the retina and optic nerve are intact. The A scan showed for the right eye an elongated axial length of 28.49 millimeters and left eye 26.24 millimeters, showing asymmetry. And, all these are just adding up, that decrease in vision in the right eye, that atrophy in the macula in the right eye, and the asymmetric axial length in the right eye, it's longer than the other one. So, it's pointing to the direction of, pathological myopia. We took OCT macular cubes for each eye. And as we look here, another example of a posterior staphyloma showing up with, imaging. This area right here is shadowed along right here in the other eye, and that's indicative of a staphyloma there. We couldn't pick this up funduscopically. But when we look at the thickness, here is just diffuse macular thinning in the right eye. And left eye is holding up pretty well, which is minor thinning here nasally. When we look at the ultrasound imaging for the right eye, thin choroid layer, and there's like this accumulation in the sub-RP layer. When you look at this, you could think, for sure it's RP hyperplasia with like pigmentary disturbances. But I was more concerned, because there's atrophy, is there actually a choroidal vascularization membrane there that's hiding that we can't really differentiate because of that clump material? And we look at the left eye, we have a thickened RP layer and a thin choroid layer. But as of now, just looking straight on this, there's no subretinal fluid that we can see. Alrighty, so what I decided to do was an OCT angiography for this patient. we look here, it's a great tool to have, a software to have, because it's non-invasive and it provides great quality images of the fundus and also lesions that are possibly there. As you can see here, it's quite hard to see, but there's purple segmented lines, dotted lines, I should say, and there are segmentation lines. We have two of them. You can maneuver them individually to get the slice that you want, because what it does, what the software does, you can assess the anatomical layers of the retina. And on the left-hand side, it's a guide. You have the overall retina. You can look at the vitreoretinal interface, looking at that, the diabetic neovascularizations, superficial capillary plexus, deep capillary plexus, and the avascular zone, looking at, CNVs from wet AMD or chronic CSRs, choriocapillaris, choroid. And what this software does, it takes an image of the retina and the blood flow at that moment. And it's highlighted, that blood flow, in red. Of course, the choroid will have blood flow, so it's going to be reddened. But when we look at this actual lesion here, the outer edge of it, it's reddened. So that's an alert that there's possibly a CNV present. And when you look up directly into the fundus image, we're worried about this area right here, possibly here as well, and maybe here as well. And what you can do is, again, maneuver the slices so you're able to go in deeper of the lesion. Again, we're worried about this area and deeper. And this is just a real-time video of us scanning. So again, this software is great to have, with this patient, because the retina is pretty injured with the atrophy and the staphylomas. So it makes it hard to, get an even image of the retina, but still gives us very valuable information. And I urge, us clinicians, when we do imaging with OCT or OCT angiography, double click on that ultrasound image. Just don't read the macula from straight on in the fovea, because, the macula is large, right? So double click it and move the cursor all the way to the top and scroll all the way down, because you might miss something. There's findings there that could be there. So with this patient, this is what we did. We just scrolled and looked through the whole lesion. As you can see right here, this is the outer retinal tubule. It's just a response to retinal injury. It's common with wet AMD with the neovascularization. The photoreceptors lose their adhesion, their structure, to stay in line with their layer. They fold and cause this tubule. And as you can see, again, reddened because of the choroid, some blood flow showing here, but as we scan more, that blood flow becomes more apparent. Bottom left, bottom center, again, more apparent. And then finally, we find a spot that looks more typical for CNV, that dome-shaped appearance in the sub-RPE. And as you can see, it's reddened, there's blood flow in there. But luckily for this patient, there's no subretinal fluid. So currently it's, you can say, quiescent, it's inactive, it's not leaking any fluid. So some differential diagnoses for this patient, of course, pathologic myopia, staphyloma, AMD, and because of the atypical appearance of those punched out lesions, we're thinking presumed ocular plasmosis syndrome, multifocal choroiditis, and panuveitis. But when we asked those important questions, he said no to everything. So it's something we got to keep in the back of our minds to just kind of monitor along with the pathological myopia. So again, this patient has pathological myopia, more so in the right eye than the left eye. It's stable from the last follow-up, which was last September. There's no subretinal fluid. And our imaging, confirms that. And the A-scan shows the asymmetric elongated axial length, again, more on the right than the left. And that choroidal atrophy, again, it's atypical for that myopic fundi. Of course, maybe it is just the myopic fundus, but it gives us some pause. So it's something which is going to also, keep a look at a little closer. And because this patient has been stable since last September, we're comfortable in saying, come back in 6 months. We're going to do a DFE, OCT macular cube, and also OCT angiography. Let's say you were to acquire this patient for the first time. You'd watch them a little bit closely. If they had an inactive CNV, you would say, come back in 2 or 3 months for the DFE and those special tests. Once you acquire that patient more and have more follow-ups with them, and there's a confirmation of stability, then you're able to increase the intervals of those follow-up visits. So high myopia is defined as spherical equivalence of greater than or less than -6 diopters, or axial length greater than or less than 26 millimeters. It becomes pathologic or degenerative when there's structural damage due to that elongated axial length, which causes retinal breaks, detachments, myopic retinoschisis, macular holes, myopic choroidal neovascularization, choroidal atrophy. And the next stage, if it were to happen, when the macula is actually affected with atrophic myopic maculopathy. And this is the equivalent of atrophic AMD. There's extensive choroidal atrophy in the macula, causing a decrease in vision, that pigmentary clumping, possible CNV, and the progression is associated with age, axial length, staphyloma, myopic CNV, or myopic retinoschisis. And of course, the next phase of this condition, where it progresses, is actually acquiring a CNV, neovascular myopic maculopathy. It's a proliferation of the choroidal neovascularization. 5 to 11% of pathologic myopia patients develop CNV, and the risk factors are retinal atrophy, lack of cracks, choroidal thinning, like my patient did have. And a summary of the disease process of myopic CNV, you have that increased axial length that causes a disruption of the Brooks membrane, causes a metabolic imbalance. There's an increased exposure of VEGF, and the CNV develops. And treatment and management for myopic CNV, let's say it's active, it's exudative CNV. Anti-VEGF is very effective. They've shown that actually Lucentis and Eylea is actually approved to treat myopic CNV. However, Avastin, the less expensive option, is also shown to be effective as off-label treatment. Like with our patient, it's an inactive quiescent CNV with regular monitoring with DFV, and importantly, with OCT macular cube and OCT angiography, we're able to monitor patients in office, and we're able to monitor them with confidence and being comfortable in seeing them in 2 or 3 months, or they're stable in 6 months. And lastly, low vision rehabilitation. If, obviously if functional vision is deteriorated, they're able to assess with devices. In conclusion, pathologic or degenerative myopia is defined by the presence of structural changes due to axial elongation, causing vision-threatening conditions such as retinal detachment, myopic retinoschisis, macular holes, or like my patient, choroidal neovascularization, and choroidal atrophy. And this case overall just highlights the importance of OCT, CIRRUS imaging, and angioplex. We wouldn't be able to find that CNV if it wasn't for the OCTA, because again, that area had all that clump material, RP hyperplasia, and OCTA was able to really dive in and find that lesion. And that concludes my presentation. Thank you.
Well, thank you so much, Dr. Martinez. I think what I love about this case most is what you highlighted at the end, that OCT angiography is the only technology we have available to assess quantitatively quiescent or dormant CNV, right? Versus, let's say, if you want to see the activity level, then you have to go on and do IV fluorescent angiography, which is going to show you the leakage component, but not necessarily the vessels themselves in high detail like OCT angiography is.
Yeah, it's a great tool to have in your office. You want to monitor these patients. And this is an interesting case. It was one of those where it could be myopic CNV or maybe histo. But either way, we have a quiescent CNV that we have to monitor in office, and we're able to do that with OCTA.
Well, my question to you, Alex, is really back to the title of your talk. First of all, very nice job. You accomplished a lot in about 12 minutes. Your talk title, Myopic CNV, Now What? Well, Alex, now what? To treat or not to treat? Yeah.
So I would say don't treat right now. It's quiescent, leave it alone. It's like a sleeping dragon, let it be. But if there's ever a time when you see any fluid, like intraretinal fluid, subretinal fluid, subarachnoid fluid, then of course refer to retinal specialists in a timely manner to get those anti-VEGF injections. But now we're able to just monitor in office.
Yeah, my focus is most definitely going to be on the left eye for this patient because he's monocular and he's young, and the left eye is also at high risk of developing CNV. And so I'm going to serially monitor him with like a 3mm OCT angiography cube on the center of the macula to pick up any really early CNV membranes.
Exactly.
I'm going to show you guys a case here that I've had of myopic CNV, which tends to be type 2. So it's subretinal. We call type 2 CNV. So between the photoreceptors and the RPE here, you can see this patient had a hemorrhage. So clearly it was active versus being like dormant or quiescent in nature. And this is the OCT angiography. You can see this membrane really nicely. And just based on how the morphology looks different than yours, Dr. Martinez, how it has these like lacing capillaries on the edge of it, that's also telling you it's probably active versus dormant, where yours had kind of these longer filamentous type of vessels.
Yes.
And then what was really nice about OCT angiography is that you can use it to monitor regression of lesions. So as you were saying, anti-VEGF is definitely indicated if you have an active lesion. And OCT angiography is another tool that you can use to ensure that your treatment is effective and that those lesions are actually regressing.
Exactly.
You know, myopia is something that optometrists have been investigating for, you know, it seems a century. And of course, myopia management right now, there's probably no hotter topic in eye care, myopia management, myopia control. But I'm also pleased to see optometrists beginning to think of high myopia as a retinal disease, right? And just a general ocular disease. It certainly is one of the top 5 causes of choroidal neovascularization. And when you look at tractional maculopathy, when you look at atrophic maculopathy, and now neovascular maculopathy in our high myopes, you know, it seems to me that Zeiss probably ought to do a whole webinar on myopic retinal disease.
I wonder if they're doing that on Wednesday.
But Alex, you threw another term out there that's fairly new, and I know you didn't make it up. You started talking about quiescent CNV, or non-exudative choroidal neovascularization. It sounds almost like an oxymoron. Non-exudative CNV, don't these membranes leak? Don't they bleed? Don't they cause trouble? How would you define, you know, a quiescent choroidal neovascular membrane?
I think simply one, obviously that's present, but it's not actively leaking. So like ours, we saw, you know, because you have these CNVs that scar and they're just there, you know, but this one had active blood flow within the lesion. But since it's not actively leaking into this, you know, the retina, I would say it's quiescent.
And we see these in other neovascular retinopathies, and AMD and angioid streaks and other causes. Of course, we need to stay on top of them and monitor for progression and fluid and heme and things of that nature, but they don't necessarily need to be treated right away.
Yes.
All right, let's move on to our next case.
Oh, we have
Dr.
one more. It looks like we have a question from the audience. Dr. Martinez, did you read anything about a Fuchs spot that is found with pathological, you know, myopia? So Fuchs spot, one of the telltale signs that's a dead giveaway, isn't it, Dr. Martinez?
Yes. So, you know, I did read about, when you think about like atrophic AMD and then myopic CNV or maculopathy, they're like cousins. They're pretty much the same, but, you know, different disease processes. Of course, with myopic CNV, you'll find that pigmentation. So I didn't read exclusively of like a Fuchs spot being a sign of it, but I mean, if it's there, you know, it's resemblance of AMD as well.
Good.
Terrific. Let's go on to our next case.
My name is Laura Chan, and the title of my presentation is Imaging Beyond the Posterior Pole in Central Retinal Vein Occlusion. So a 70-year-old American Indian male reported painless gradual vision loss of his right eye for 6 months, and he missed his routine eye exam scheduled for 2 months ago due to the COVID-19 pandemic. Ocular history includes non-exudative AMD, which he takes AREDS2 sporadically. Medical history includes diabetes type 2 for 6 years with the last HbA1c of 7.5%, hypertension for 10 years, hypercholesterolemia, malignant melanoma of skin of lower leg, acid reflux, and benign prostate hypertrophy. He was a former smoker, which he quit 20 years ago, and here is a list of his medications. So unaided visual acuities were 2300 in that right eye. Pinhole, no improvement. Left eye was 20/20. Pupils were equally round with a mild APD of the right eye. Confrontation visual field, he was able to detect hand motion in all quadrants of the right eye, full to finger count in the left eye. Extraocular motilities were full and smooth. Blood pressure was 128/81. On external exam, it revealed combined myocataracts of grade 1+ in both eyes, and intraocular pressures were 18 and 16 within normal limits. So this is an ultra-wide field montage, which required 2 shots and spans 200 degrees horizontally of the left eye. So there's a bit of hard drusen in the macula, as well as a black heme that's likely due to his cardiovascular risk factors, as well as some reticular degeneration seen inferiorly. This is a close-up, and here we can see that the real color as well as high resolution is still retained, and we can clearly see the defined field hard drusen and a bit of macular pigment modeling in the macular area. This is the patient's right eye. This is an auto montage which required 4 shots and is 200 degrees vertically and horizontally. Here we can see diffuse intraretinal hemes in all 4 quadrants, as well as dilated and tortuous retinal veins, some peripapillary splinter or flame hemes below the optic nerve, as well as suspected macular edema just from the appearance, as well as some optic nerve edema. This is a close-up, and so we can see that there's a bullous or kind of like a convex appearance to the macula area, as well as some indistinct disc margins more nasally on the nerve, which would both suggest macular and optic nerve edema. So a macular cube OCT was performed, and going horizontally through the foveal area, we can see significant cystoid macular edema, as well as some subretinal fluid, which is quantified on this report here to 799 micrometers centrally, which is much thicker than the left eye. This is an optic disc cube, which helps us confirm that there is some mild optic nerve edema with a thicker average RNFL on the right side, as well as a consistently higher RNFL thickness, and as well as some fluid seen on the tomogram. This is an angioplex montage OCT angiography, which requires 6 scans, and then it would compile it together. Angiography is essentially successive OCT-B scans at one single segment, and then it's able to derive this retinal vasculature mapping depending on how much blood flow there is in the vessel. So if there's very limited or no blood flow, as in ischemia, then there would be a blackout or gray shade to the area, as in the foveal avascular zone. So this is a side-by-side comparing the fundus photo of that right eye to its angiography scan, and that way we can make correlation if we're suspecting that at a certain location that there's something interesting going on there. So on the left-hand side, we have a normal eye, and then in our patient, we're suspecting that there's a central retinal vein occlusion. And so this montage allows us to view both the posterior pole as well as the macula all in one shot. So this is the OCTA specifically of the optic nerve head. So a feature of chronic CRVO is sometimes the appearance of collaterals. So if the collaterals were present, it would show up as an abnormal blood vessel in the angioplex scan, which this patient does not have. This is the OCTA 3 millimeters of the macula. So the smaller the area, the higher the resolution. And so on the left-hand side, there's the superficial capillary plexus, which extends from the internal limiting membrane to the inner plexiform layer, which the CRVO can affect. So on the angioplex scan, we can see that the foveoavascular zone, the contour is more ragged and irregular, as well as there's black areas scattered more in the upper portion of the scan, which can indicate a little bit of non-perfusion or capillary dropout, such as ischemia, and or it can be a combination of some of the edema that it's capturing. And on the structured superficial scan, we can see the areas of the intraretinal fluid very clearly. In the deep capillary plexus, it extends from the inner plexiform layer to the outer plexiform layer. And this scan is less distinctive. It's harder to define just because it's cutting through a lot of the intraretinal fluid as well as the subretinal fluid. And that's why we can't see some of the blood vessels or vasculature of the deep capillary plexus. So this is a comparison of our patient compared to a normal eye. So as you can see, the foveoavascular zone, the contour is more ragged, more irregular, and there might be some areas of ischemia or dropouts. And on the deep capillary plexus, we can see that the edema is blocking out a lot of the signal. Some of the differential diagnoses from these clinical findings can be very severe non-proliferative diabetic retinopathy with centrally involved DME. However, in our case, it's very asymmetric between OD and OS, and there's a combination of flame hemes and dot hemes. And unilateral disc edema is not typical for NPDR, even with edema. Ocular ischemic syndrome would be more unilateral, but the veins, although dilated, are usually not tortuous, and the distribution of hemes is mostly in the mid-peripheral area and not diffusely in all four quadrants, as we can see in this case. As well, usually the disc would appear pale, but not necessarily have edema. NAION might be one if we didn't see the rest of the vasculature findings, since this patient did have a small CD ratio or disc at risk appearance. And NAION also is related to the cardiovascular risk factors. So a retinal vein occlusion is the second most common retinal vascular disease after diabetic retinopathy, and it's important to classify whether it's ischemic, which is more than 10 disc diameters of non-perfusion, or non-ischemic. And the treatment and the visual prognosis between ischemic or non-ischemic is large, in which the ischemic, there's a worse visual prognosis and there's a higher likelihood of the patient developing neovascularization in the future. And in CRVO, it's more likely to be anterior segment, and that could lead to neovascular glaucoma. So utility of OCT angiography in retinal vein occlusions, of course, with the montage, it can help determine how much non-perfusion or ischemia there is, and that would help in the classification. And it could also help us note any abnormalities in the blood vessels, such as telangiectasias, preretinal neovascularization, and collaterals on the optic nerve head. Management, the patient was referred for anti-VEGF in order to help with the cystoid macular edema. If the patient doesn't have an updated blood work or medical examination, those are suggested in order to determine what the risk factors are. And of course, communication to PCP and education of the patient regarding this condition, helping the patient manage the systemic diseases as good as possible, and the higher risk of vein occlusion in the fellow eye and risk of cardiovascular diseases and strokes. And this patient was on a diuretic hypertension medication, which is also a known risk factor. So the take-home message is that this montage OCTA is very helpful in determining whether the CRVO is ischemic versus non-ischemic, and that could really change the management as well as the visual prognosis. And vision loss in CRVO most commonly is due to macular edema, but macular ischemia as well. And OCTA can also detect preretinal neovascularization later on. Thank you.
Well, thank you so much, Dr. Chan. Love those images. And I feel like Zoom, the video really doesn't do it justice. The auto montage shot that you got, the 4-piece montage of the central retinal vein occlusion was absolutely gorgeous when you showed that to me. So did you think, Dr. Chan, that this was ischemic or non-ischemic central retinal vein occlusion based on the OCT angiography montage?
I think it's non-ischemic just because there wasn't the tendus diameters of ischemia or non-perfusion or blacked out spots on that angiography.
Agreed. Yeah. And what I love about this case is that, like, based on the clinical presentation with the really poor acuity of like 2300, the like grade 1+ APD, it would have led me to think like it could have possibly been ischemic. But then when I look at the OCT angiography, I'm reassured that, okay, once the macular edema is treated and it calms down, this is something that I can monitor because the risk for neovascular glaucoma and anterior segment neo is low.
Yes.
Kind of get that reassurance from it.
And so I agree. The montage option with Angioplex is really, it's a game changer already. And what we're seeing is that the more non-perfusion there is beyond the posterior pole, you know, the greater number of anti-VEGF injections that patient is probably going to need. And we know that that's true about diabetic retinopathy as well. So I guess, you know, the moral of the story is go beyond the posterior pole in assessing these common retinal vasculopathies. Now, Dr. Chan, this is another well-presented and impeccably managed case, but let's make believe that your patient was 40 years younger, 30 years old instead of 70 years old, with a CRVO and some macular edema. How would your thought process differ in terms of etiology and management?
Yeah, so I think that if there wasn't like the identifiable risk factors that my patient had, like the hypertension, diabetes, and hypercholesteremia, I think I would ask whether they are on any oral contraceptives, whether they're taking any hypertensive medications that they might not know what it was for. And then it's very important to send the patient for some blood and lab work to make sure they don't have something like a hypercoagulable state or some kind of blood disorder that changes the platelets or the clotting factors. And they also some baseline autoimmune or inflammatory disorder antibody testing to make sure it's not some kind of vasculitis like sarcoid or syphilis or SLE.
Excellent. Oh, love that answer. Yeah. I think another thing to add to that is to ask yourself, do gonioscopy, not only to look for anterior segment neo, but also say, is this possibly a patient that went into intermittent angle closure? And so the pressure spiked really high, which caused the central retinal vein occlusion. It was just a really close association between glaucoma, open angle glaucoma that is, and vein occlusion. So like once you've had a vein occlusion, in my book, you're like glaucoma suspect for life.
Excellent case. Shall we move forward to our final?
Good. Dr. Mancha, take it away.
Good day, everybody. My name is Saul Mancha. I am a recent graduate of the residency program at the University of Incarnate Word, Rosenberg School of Optometry, class of 2020. Today, we'll be covering a case, a MACTEL-2 case that we've been following at in the school's clinic for the past 4 to 5 years. And we've been using multimodal imaging. No financial disclosures to report at this time. So today, our goal of this presentation is to, really just kind of talk about the etiology, treatment, and prognosis of macular telangiectasias. We'll review our patient's exam findings from 2015 and compare them to 2020. as well as the multimodal imaging techniques that were used to monitor the condition. This report aims to emphasize the use of spectral domain OCT, angioplex OCTA, and multicolor fundus imaging to track early changes of the retinal capillaries and monitor for neovascularization and other signs of progression. So what is MACTEL? MACTEL type 2 is a neurodegenerative retinal disorder that typically affects patients later in life in their 40s or 40s to 60s. The symptoms that patients may report to clinic with would be, progressive decrease in vision, metamorphopsia, and/or sometimes scotomas. The precise pathology of the condition is not well understood currently, but there are some literature that has suggested that these appear to be a degeneration of the MACULAR cells in the retina. That, with these degeneration, these actually lead to structural changes that we are able to appreciate funduscopically and on OCT. The condition is known to show retinal vascular changes that are thought to be secondary to endothelial cell damage, and these typically have an association with hypertension and sometimes diabetes. Okay, so there are a few types of macular telangiectasia. Type 2 is going to be by far the most common, and it's usually going to be found again, patients in their 40s to 60s. Type 1 is congenital and typically going to be unilateral, so it's an easy way to tell the different types if it's one eye or both eyes. And type 1 seems to be a variant of Coates disease. And type 3 is even less understood, and these are primarily going to be like occlusive phenomena, which are rare. Okay. So on slit lamp examination of these patients, what we'll see is some grayish hue of macular tissue, pseudo-hole appearance, and then also crystalline deposits. Some differentials for these patients when you have them inside your office, of course, be macular degeneration, branch retinal vein occlusions, and also diabetic retinopathy. So let's meet our patient. Our patient was a 64-year-old Hispanic female. She's been followed by our clinic since 2015. She was previously seeing a retinologist, but due to financial constraints and loss of insurance, she was no longer able to keep her follow-up appointments with a retinologist, so we started tracking her at the school. When she first came into our clinic, she thought that she had age-related macular degeneration, is what she remembered the retinologist telling her. But after we consulted with her retinologist and exchanged notes, we had seen that they actually did a fluorescein angiography, and they were able to decipher that this was not age-related macular degeneration, but in fact it was macular telangiectasia due to wreath-like late-phase leakage around the fovea in both eyes. So our patient, since 2015, she's always had a complaint of progressive decline in vision in the left eye and metamorphopsia. And, similar to other type 2 patients, she also has a long-standing history of hypertension and also hypercholesteremia. Okay, so in the patients in this graph, we can see on the left-hand side, 2015, the vision in the right eye is 20/20, the left eye was 20/40, and anterior seg was typically, unremarkable. Posterior segment, we had thought she may have had a few soft drusen, some mild puckering, and we'll see why here in a minute when we look at the fundus photos. In 2020, her vision in the right eye remarkably had stayed the same. She was still 20/20, 5 years out, 4 to 5 years out. The left eye did show some slight decrease. So she, went from 20/40 to 20/70 over that 4 to 5 year span. And again, no changes to anterior segment, and then the posterior segment, we'll actually look at some fundus photos of 2020, and so we kind of really get a better idea of what's going on inside the eyes. So unfortunately, I do not have the colored fundus photos from 2015, but I do have them from 2017. And in the right eye 2017 photos, we notice a not so subtle color irregularities of the temporal parafoveal region. And at first glance, this resembles, you know, a pseudo hole. And there's going to be kind of highlighted by these purple arrows and this area right here. Within the pseudo hole, we can appreciate a hypo color changes that were likely thought to be the soft drusenoid deposits from the 2015 examination. And these are these little green, there's going to be this green arrow right here. We can also appreciate that the patient has an apparent loss of a normal foveal light reflex, which is very typical in these patients with MACTEL type 2. And if we really scrutinize the temporal parafoveal region in the right eye, and we can just squint a little bit, we can make out a little bit of the graying of that macular tissue. And it's much more evident in the left eye, but this one's going to be on the nasal portion. And so that's some of the grayish tissue, the loss of a natural color of the macular tissue that we're going to expect with MACTEL type 2. So here we have a color photo, a fundus photo of the patient's last visit in 2020 in July. First, I would like to kind of remark that there is a flash artifact in both the right and the left eye that have the exact same appearance here. And so we know that's not within the actual tissue itself. This is just from the camera. So we're going to try to ignore those. In the right eye, even though the flashing is a little bit higher than 2017 photos, we can easily delineate the macular color changes that resemble a pseudo macular hole, and we can better visualize the grayish hue that surrounds the parafovea. So this is now with the purple arrow and the purple circle. This is highlighting the pseudo hole appearance. The green arrows are kind of again highlighting those drusenoid appearing deposits. And the red arrow is highlighting the temporal graying or grayish macular tissue. So working in the school's clinic, we have access to multiple different diagnostic imaging equipment, and this allows us the opportunity to better educate the interns as well as the patients themselves. These FAA photos were taken on the patient's last visit with us in July of 2020. The fundus autofluorescence is generally with normal limits in both eyes on first glance, but if we kind of blow it up, we can see that there's a very noticeable mild mottled area of hyperfluorescence. This is going to be highlighted with a green arrow. Seen in the temporal and superior parafovea in the right eye, and these changes can be seen in the left eye as well, but noted easiest in the temporal area. These subtle findings are consistent with RP disorganization and/or some of the migration that is seen later in the disease process of macular telangiectasia type 2. So for MACTEL, these are things that we can actually follow in office with OCTs, kind of checking for these, microscopic changes to these retinal layers. And so some of the classic findings for macular telangiectasia type 2 on OCT imaging is going to be changes to the outer retinal layers, some draping of the internal luminary membrane. Sometimes they may have crystalline deposits forming in the intraretinal layers. And one of the biggest things we are going to kind of looking at, and we'll get a better detail of this on the next few slides with the OCT-A, is going to be the ectatic juxtafoveal capillaries. And these can also be kind of appreciated as having like a right-angled turn where they're diving into the deeper retinal structures. And with the OCT, what we're really trying to, hone in on and pick up early is any kind of signs of neovascularization. And these are typically going to be subretinal or sub-RPE neovascularization in these macular telangiectasia patients. Okay, so here are a few macular change analysis scans of the right eye and the left eye. These were taken about 5 months apart. And we're looking for any kind of changes in the macular thickness. And this tool is very useful to monitor for thickening or enlargement of these cavitations that we're seeing in macular telangiectasia. And this will kind of clue us in if there's any thickening, if there's also an associated leakage going on, or if there's some RPE neovascularization that's pushing forward. On these particular set of images, we can see that the macular thickness has remained relatively stable over this 5-month span. And here we took the slice navigator and kind of cut through these cavitations on both the right eye and the left eye. And first, what we're going to look at once we blow this image up even further is, this green arrows is highlighting these cavities that are forming within these retinal layers. And what we also start to appreciate is that we're starting to get a thinning and disruption of these outer nuclear layers. And this is going to be highlighted with that purple arrow and kind of showing that irregular shape, that it's no longer nice, robust, and thick. With these patients, we also tend to find that the ellipsoid zone, with this red arrow is highlighting, has some disorganization or disruptions. And this is also followed through to the photoreceptor outer segments, which is going to be this blue arrow here and a really faint blue line. So thanks to advances in technology, we're able to really provide patients with the utmost care with this novel, non-invasive, and very user-friendly feature of our OCT. And the OCTA is going to provide us the ability to visualize, inspect, and monitor the retinal vasculature for early structural changes, which in our case, in our patient's case, is immeasurably important for us. And so here I was able to put together, and with my very limited copy and paste skills, an anterior to posterior imaging sequence as we work our way through the various retinal layers. Now for the OCTA, this is much easier to scroll back and forth through on the actual device than it is on the PowerPoint, of course. But here we are, kind of looking at the VRI, which is the vitreoretinal interface, and these are helpful to kind of track for any kind of capillaries that are kind of extending more anterior than the surface layer. On this RDE is the retinal depth encoded. This software puts together and it tries to highlight any kind of areas where the capillaries are in the superficial or if they're in the deeper structures, and kind of tracking some changes. And I did want to point out on this image, and I think it highlights it very well, is that there are little aneurysmal little bulbs here in the temporal portion, and these are very typical of these MACTEL patients to have those little end bulbs. On this next layer, we're looking at the superficial portion of the retinal capillaries. And here again, we're highlighting, on these OCTA images, these irregular aneurysmal parts of the capillaries. And this is, again, still in the right eye. As we move a little bit further deeper, we're getting into the deeper structures, and we're noticing some of those vessels that were on the superficial layer are, again, turning and having the right angle of turn where they're going into the deeper retinal layers. And some of these push back into the avascular layer of the retina. And then moving further back, we're able to get to the outer retina and the cocapillaris portion of the scan. And then really what we're looking for here on this next scan, this is going to be the RPE scan. And this is where we're going to be looking for some of those early subtle changes that may show neovascularization in these macular telangiectasia patients. And so together with this RPE and this sub-RPE, we're looking for any kind of irregularities that might indicate that there's some kind of presence of neovascularization. And for this patient, after scrutinizing the patient in office through these scans, we're able to kind of rule out that there was no signs of early sub-RPE neovascularization. So here is a perfect example of how easy it is for the clinician to scroll through some of these structures in office with the machine. So here's a video, and this video is actually just scanning from the superior macular tissue down to the inferior macular tissue. But what we're looking for here is we're able to kind of track and monitor, how to what extent these cavitations are, taken up within the foveal region and the parafoveal region. Okay, and so this next one is one of my favorite parts of the software at this school, is that here we have the patient's previous scan from 6 months prior, and this was going to be of the day of 2020 in July. And we're able to kind of compare these OCTA changes one with angiography, then also two with the thickness. And so having both of these together is really going to provide a better diagnostic capability for the clinician to kind of seek for these early vascular changes and correlate them with these structural changes, and get a better idea if it's time for the patient to get sent back to a retinologist for a fluorescein angiography to look for these leaking patterns, and again checking for the neovascularization. So conclusions, this condition is just a neurodegenerative retinal disorder. These typically stabilize, after a while, and the vision for most patients remain around 20/40. Our patient, her vision on the left eye is 20/70. It's not uncommon to get to 20/70. It's just that the 20/40 is the typical finding. This is a condition that can be followed with diagnostic technologies, and kind of sent out for treatment, whether it be laser photocoagulation or whether it be anti-VEGF therapy by the retinologist. But this is something that we can use non-invasively inside the clinic to kind of monitor these patients closely. Here are some of my references for the information throughout the slides, and here's my contact information.
Well, thank you so much, Dr. Mancha. That was an excellent case.
Thank you. Thank you.
And we do have a question, which is, so can you only initially diagnose MACTEL by using fluorescein angiography?
So this is a little bit harder to do with just fluorescein angiography in itself. Really, you're going to need to look at these microstructural changes that OCT is going to highlight, where fluorescein angiography is just going to tell you if there's leakage, right? So again, both are going to be able to pinpoint these end bulbs or these capillary ectatic vessels within these macular or parafoveal regions. But fluorescein angiography is going to give you a better idea, is it leaking? And then the OCT and OCTA is going to give you a better idea, how does the structure actually look, and finding these small cavities, essentially in these inner and outer retinal layers. Great question.
I agree. That's a great question. And I think OCT angiography is actually more powerful for diagnosing like really early macular telangiectasia type 2 than conventional IV fluorescein angiography, because the microvascular resolution is better and superior, because leakage isn't like obscuring your view of those like subtle vascular telangiectasias and microaneurysms that are present in the temporal macular area. And then we had another question: how would you differentiate neovascularization in MACTEL versus AMD? Another great question.
Yes, again, so with AMD, we know that this is going to be a problem with the RPE layer, right? And then causing some breaks, and we get some of the vessels kind of growing through the RPE. Whereas with MACTEL, we know that there's the superficial capillaries that also have this, that are also problematic. And so again, I think the OCT is going to be paramount in deciphering, where is the action happening versus just fundus photography or even FAF. FAF, again, is going to highlight these changes a little bit better for the age-related macular degeneration, and also kind of weed out, is it MACTEL or not? But again, I think the biggest point for the presentation is knowing that the OCT is going to be your biggest friend in kind of diagnosing and monitoring these patients.
Yeah, it's making that distinction between interretinal circulation problem in macular telangiectasia type 2 versus primary choroidal and choriocapillaris pathology in AMD. And OCT and OCT angiography can do that very easily for you.
Oh, yeah.
And in MACTEL type 2 in particular, that telltale feature, the internal limiting membrane draping over the area of cavitation, is another differentiating feature. And my question to you, Dr. Mancha, and by the way, great job on the presentation, wonderful imaging. It would be tempting to have the patient treated with anti-VEGF injection in a case like this. But we decided to go ahead and follow this patient without treatment. Under what circumstances would it be appropriate to treat with anti-VEGF?
So, again, the second that we're actually seeing a large amount of leakage or that there is the actual neovascularization, there have been a couple of studies that have proven that the anti-VEGF therapies for these MACTEL patients in a neovascularization state is not going to be beneficial for the patient. So you're essentially, doing an invasive procedure for something you're not really going to help in the long run. So with these patients, again, just keeping them in office until it's time for, the visit to the retinologist and doing a fluorescein angiography if you're really suspecting that there is that neovascularization. So neovascularization, anti-VEGF, if it's just regular MACTEL without neovascularization, we just watch it, every 4 to 6 months.
Yeah, if you have the technology, you have the training like you do, you can easily make this diagnosis by yourself and then monitor it in office or refer to your, friends over in low vision rehabilitation. So you can keep it within optometry until it reaches that point of proliferation and then actually requires anti-VEGF therapy.
Oh, yeah.
And the multimodal imaging that you're highlighting, and really all of you highlighted on all these cases, your referrals are going to be much more informed when you do need to get treatment. Last thing, MACTEL has been known to cause full thickness macular holes. So just to keep that in mind as well.
Oh, yeah.
That's a great point. I'm going to briefly share a case here of when you would actually want to refer. And so this was a patient, I'm showing you just the left eye here, obviously far more advanced than Dr. Mancha's case that he presented. But a patient that has this pigmented plaque on the temporal side, which is characteristic of late-stage macular telangiectasia type 2. But then what I want to point out are these like whitish opaque subretinal areas superiorly and nasally, which correspond to this like subretinal mass between the photoreceptors and RPE on our raster scans. And there's another one here superiorly, this subretinal mass. If we look at OCT angiography, it gives us an idea that those masses are actually vascularized. So there's two really well-formed subretinal neovascular membranes, which may require treatment, right? So this was a patient that I did refer out. The question then, is this active or is this just dormant or quiescent CNV again? Because there's no hemorrhage around it, there's no fluid on OCT. So I think this patient would then benefit from IV fluorescein angiography done by a retina specialist and potentially anti-VEGF treatment. But if there's no neovascularization, there's no need to refer, in my own personal opinion.
Yeah, MACTEL is such a unique condition. Really, nothing else behaves like this. Sometimes we think of it as a very subtle form of Coates disease.
Yeah. Oh, well, thank you everyone for attending. We had an excellent session, and I want to thank Zeiss for their support for this session. I want to thank our resident alumni faculty members. And then Dr. Pizzamente, thank you so much for agreeing to collaborate on this project with us.
Always a pleasure to be with you, Carolyn, and wonderful job to our graduating residents. And thanks once again to our friends at Zeiss. And don't miss the next resident grand rounds. There it is, myopic complications. How about that?
Great, so Wednesday, 7 p.m. Eastern. Tune in, and if you enjoyed this session, there's another one coming this week. Have a good evening, guys. Stay safe.
Thank you.